Today we will be discussing testing for syphilis, perceptions and barriers among men who have sex with men, or MSM. We will start off with some facts about syphilis. These are facts taken from the CDC website. So cases of primary and secondary syphilis have increased by 71% in 2017 since 2014. 64% of syphilis cases between 2017 and 2018 were among men who have sex with men. Of those cases, 45.5% also report to be HIV positive. These statistics alone just show the importance of preventative measures that need to be taken place to mitigate the prevalence rates of syphilis among men who have sex with men. The purpose of the study is to understand perceptions of syphilis testing among men who have sex with men, while also identifying barriers to syphilis testing. Some research questions to consider. Notice that there are two phases. This is because the study will focus on the explanatory sequential mixed methods design. So for the first phase, we will be doing a quantitative research design where we are going to focus on what is the relationship between perceptions of syphilis and testing for syphilis among men who have sex with men. The second phase will move on to qualitative research where we want to know what factors influence syphilis testing among men who have sex with men and how can they be addressed to promote regular testing. There are also some sub-questions to follow. How do men who have sex with men perceive their susceptibility to testing positive for syphilis? How do men who have sex with men perceive the severity of syphilis? How do sexual behaviors impact their decision to get tested for syphilis? How do testing sites influence their decision to get tested for syphilis? And lastly, how likely are men who have sex with men to get tested in a year if engaging in sexual intercourse with multiple sex partners? That last question is there because according to the CDC, it is suggested that men who have sex with men get tested at least once every 3 to 6 months if they are sexually active and if they are having sex with multiple sex partners. Okay, we will move on to the literature review. Most of the research presents the similar barriers to getting tested. These are the common themes that were found in research studies. Clinical barriers, men who have sex with men who are asymptomatic, as well as sexual behaviors. Clinical barriers include providers' response to men who have sex with men, confidentiality, stigma, discrimination, availability, and time. Providers' response is just that. 2 studies focused on providers' response and reception towards men who have sex with men. Providers did state that they did feel uncomfortable talking about sexual activity among this population. They also did not feel comfortable having them get tested and requesting that they get tested, even though they knew that they were sexually active and performed high-risk sexual behaviors. This goes on to stigma and discrimination. Men who have sex with men feel discriminated against in healthcare settings. There were certain studies that followed men who have sex with men who are African American, and there was also a study who focused on Asian men. And these 2 populations did state that there was just a continuous stigma associated with their race, and that caused them to not get tested. That also caused them to not even get tested for not just STDs or HIV or anything like that, but just use hospital settings in general. Confidentiality was also an important barrier. A lot of men who have sex with men felt that that actually going into clinics, walking into clinics, breach their confidentiality, especially when clinics are in places of where they work or where they live. Availability and time, that's more focused on the actual time of the appointments and availability of appointments. That caused men who have sex with men to not get tested because, again, they just didn't have availability for them, or they just didn't want to wait long wait times. Asymptomatic. So again, this is just discussing men who have sex with men who are asymptomatic. Some studies suggest that there is a lack of knowledge and understanding within this population. This also goes to low perceived susceptibility. So there are some studies that followed men who have sex with men, and In some studies, more than half of the population, or half of the respondents, I should say, did not get tested and have not been tested in their lifetime, even though they did engage in sexual activities, including condomless sex and all of that. We will be discussing sexual behaviors in the next slide. But again, asymptomatic men who have sex with men is important to discuss because a lot of the times they don't feel symptoms, so they don't want to get tested or they don't feel the need to get tested. And again, research does show that even though they do engage and they know that they engage in these sexual behaviors, they feel that they don't need to get tested because they're not expressing symptoms. And some even said that that syphilis was easy to cure, so there's no need to get tested. We are going to move on to some sexual behaviors. This includes just the satisfaction of having sex with multiple people, and that's another point here, multiple sex partners, condomless sex, and also drug use. These are risk factors that can actually promote the spread of syphilis, but we are also including them as barriers because there are some studies that suggest that men who have sex with men don't get tested because of certain stigmas also associated within their community about these, about syphilis and STDs and HIV. One study suggested that because everyone's having sex with multiple people, that if someone got tested, it was an insult to other people or to other partners if they did get tested. The drug use is also a problem for men who have sex with men who do it to get money or for monetary value. Drug use is pretty evident in, again, within that population who use sex for money. And that's also a barrier to getting tested because, again, these all fall into the asymptomatic or not having symptoms. This also falls into just the, what was shown in the previous slide, men who have sex with men have knowledge or some understanding of syphilis, and they do know the perceived severity of syphilis, but they don't have, or they have a low perceived susceptibility. So even though they engage in all these sexual behaviors, they don't feel that they're going to get syphilis. They feel that they're not spreading syphilis. So that's an important part to understand, and it's actually an important part to, it's just an important concept to grasp when trying to find out why men who have sex with men do not get tested. And that's another reason, again, because they don't feel that they are susceptible. They don't feel that they're really spreading syphilis. We're going to move on to the methodology section and the study design. So again, we are using an explanatory sequential mixed methods design. This is a two-phase data collection project where the researcher collects quantitative data in the first phase, analyzes those results, then further explains that data in the second phase while using qualitative data, which is more open-ended questions. And this would just provide a more comprehensive and better understanding of perceptions among men who have sex with men. Perceptions of getting tested and syphilis in general among men who have sex with men. There are challenges to this, as there is to every design, which include validity and reliability. We will address validity and reliability in each section or each phase. Validity and quantitative data, we will have the use of peer debriefing as well as an external auditor to kind of review all the material before. And ethical considerations, we are going to present the material to the Institutional Review Board for presentation, for approval, I'm sorry. And of course, the principles were outlined by the Belmont report. Population, sample, and participants. So here, we are going to be using convenience sampling as well as systematic sampling. So for convenience samplings, we are going to go into different clinics. We are going to pass out flyers and just talk to the staff to promote our survey. This is going to be a web-based survey or online survey that participants can take. So again, it is convenience sampling. We are just going to clinics around the area or known clinics that have a high population of men who have sex with men, notably HIV testing clinics, HIV clinics, and other clinics of that nature. For the systematic sampling, we are going to be doing this systematic sampling based off of the convenience sampling in the first phase. So the second phase will just be a result of the population that we've already studied. Again, we just want to add on to some of the questions that they've already answered in the online surveys. So for measurement, we are going to be using some constructs of the theory of planned behavior. This will just help us gain some knowledge and insight on the attitudes towards syphilis, as well as their intentions to want to get tested, to want to gain more information about syphilis, and to want to just speak about syphilis in general. That's the general ideal. We want to know where they're at with syphilis and if they want to even change their behaviors or if they even want to start promoting a positive sexual health relationship with their partners and all of that. And we will be doing online surveys as mentioned, as well as interview questions. So the second phase will focus on one-on-one interviews. It will be about 15 people, again, from the first population in phase 1. The in-depth interviews would just focus on, again, the perceptions, because there is a lot of research based on quantitative studies, but not a lot about qualitative studies and in-depth interviews and in-depth answers and responses to some of these questions. So we do know, and there is data that suggests that men who have sex with men, they know that syphilis is bad, but again, we don't know why they think that, or why they don't feel that they're at risk or any of that. So data analysis. For phase 1, for quantitative research, we are going to be using the IBM SPSS statistics software. And then for phase 2, we are going to be coding all the data and conducting interviews and recording those interviews and then just getting all the data from that. Limitations. So this study is not going to be representative of the whole or the general population, because again, this is going to be convenience sampling where we are going to maybe 1 or 2 locations and getting the population from there. It's not going to be representative of whole groups of age groups and ethnicities and all of that. That's not going to be really considered when initially promoting the campaign and the study and getting participants. Bias, that's going to occur, most likely researcher bias as well as respondent bias, depending on how comfortable respondents feel when they do the in-depth interviews, and as well as, again, researcher bias. And biases in quantitative studies where there is external validity that we need to consider as well. Integration of information, that's going to include the data analysis of phase 1 and phase 2 and combining all of that information together, because again, there is going to be in-depth interviews and we have to make sure that all questions are answered and that they are coherent and they are linked together in a comprehensive way and that we can understand. And then time and resources, this is just limitation in general for mixed methods designs. These do tend to just take more time because you are doing both quantitative and a qualitative study. And this is the presentation. Again, we are going to focus on men who have sex with men, and we do want to know what barriers and perceptions they have on syphilis testing. And that is the presentation. Here are some references that we've used in this PowerPoint, and that's it. Thank you for listening.